Good afternoon, everyone. My name is Tamara Oudyn, and I'm delighted to be your MC for today's Monday Lunch live stream. I'd like to begin today by acknowledging the traditional custodians of the lands on which we're located. We pay our respects to elders past, present, and emerging, and extend that respect to other Indigenous Australians present online. Before we kick off today's program, I just have a few little housekeeping notes for you. The VCCC has some interesting webinars coming up that you can register for via the VCCC website. And please note that today's event is being recorded, so it will be available on the VCCC Open Learning page, where you can also find and view previous events. You may also like to follow the VCCC on social media. If you do, they're on Facebook, Twitter and LinkedIn, so please be sure to tag the VCCC in all of your posts today. I see we've got quite a bit of attention on Twitter already this afternoon. We do encourage the asking of questions throughout this session, so if you have any, you can do this via the Zoom Q&A function. Just submit your questions as we roll through the presentation today, and we'll do our best to get to them at the end of the session and get you some answers on your questions today. In November 2020, the World Health Organization adopted a strategy to eliminate cervical cancer as a global public health problem. The adoption of the strategy was co-led by Australia with our strong track record of global leadership in cervical cancer prevention programs, technology and research. This is an issue that has some personal significance for me, and it's largely the reason why I'm here with you as your MC for today's event. It's thanks to these prevention programs that a routine cervical screening test conducted about this time last year for me caught some possible high-grade cell changes. A diagnostic colposcopy then confirmed that. Subsequently, I then had a loop diathermy procedure to remove the suspect cervical tissue. Thankfully, the first test of cure showed no residual higher risk HPV and all normal cells. So I feel very, very lucky indeed to live in a place where this type of screening is possible. Australia is well on track to eliminate cervical cancer by 2035 as a result of our world-leading screening and vaccination programs. Yet even here, we can't be complacent. The COVID-19 pandemic had a huge impact on screening rates as women put off their regular health checks. Last year in Australia, 930 women were diagnosed and 230 women died from cervical cancer. Today's presentation comes to you in the lead up to HPV Awareness Day, which is on the 4th of March. Our presenters will navigate the opportunities and challenges of the WHO's call for the global elimination of cervical cancer by 2100. They'll focus on Australia and the Asia Pacific in light of the latest evidence, new screenings, and the success of the HPV vaccination strategies. Mr David Wrede is the clinical lead for the dysplasia service at the Royal Women's Hospital. His main clinical focus has been in gynecological cancer prevention. He's an investigator on a number of cervical cancer screening, prevention and treatment projects, including COMPASS, led by Professor Marion Saville and Professor Karen Canfull. He's also an associate investigator in the NHMRC C4 Centre of Research Excellence. He was appointed to the board of VCS Foundation Ltd in May 2010 as director with gynecological expertise and was appointed vice chairman in 2017. Mr Wrede is an honorary senior lecturer to the Department of Obstetrics and Gynecology at the University of Melbourne. Our second presenter today is Professor Marion Saville AM. She's held the position of Executive Director of VCS Foundation Ltd since the year 2000. She's served on numerous cervical screening advisory committees in Australia. Most recently, she was a member of the steering committee for the Renewal Implementation Project. Marion is currently chairing the working group to review guidelines for the management of screen-detected abnormalities in the National Cervical Screening Program. She was appointed as a member of the Order of Australia on Australia Day 2020 for her significant service to women's health through cervical screening initiatives.
Thank you very much, Tamara. I'd like to open our presentation by giving a brief, I can't get this, by giving a brief summary of what we intend to do. And that is looking at cervical cancer in Australia, cervical cancer prevention strategies in Australia, including primary prevention with vaccination, secondary prevention with screening, and then paying particular attention to the World Health Organization's call for the elimination of this disease, and giving a global perspective and about also how this country can assist our regional neighbours in screening for disease and preventing it. It's very important that we understand that cervical cancer has long been a story of inequality that doesn't just apply between different nations, but also internally in nations. Cervix cancer remains one of the most common causes of death for women globally. Indeed, for women of reproductive age, it has now surpassed maternal mortality associated with pregnancy and childbirth, mostly because of the WHO's actions in that field. 90% of deaths from cervix cancer occur in women in low and middle income countries. We know now what we didn't know when I was at school, and that is that HPV is the causative agent of cervical cancer and is responsible for more than 90% of invasive cervix cancer worldwide. It's a virus that's extremely common in human infection. There are more than 60 types that infect the genital area of human beings, and the vast majority of those infections are transient and cause no problems. HPV 16 and 11 are low-risk viruses that cause 90% of genital warts, but there are a group of approximately 14 oncogenic types that cause more than 90% of cervix cancer. Of these, types 16 and 18 cause 70% of cervix cancer worldwide. HPV is transmitted through sexual activity. Infections are extremely common in young people and tend to clear themselves, but 10% of persistent infections with oncogenic types can lead to dysplasia, which is precancerous, and of those who have established high-grade abnormalities, 1% progress to cancer per year, and approximately up to 40% of all high-grade precancer can become invasive.
Thanks, David. I want to talk about this study that we undertook as a partnership between the Women's Hospital and VCS Foundation. And in this study, we took sequential cases of cervix cancer across public hospitals in the Eastern Seaboard, Queensland, New South Wales, and Victoria, and we typed them to determine the causative HPV type in order to better inform our vaccination and screening efforts. You see here the results in which type 16 is very oncogenic, together with type 18 causing about 80% of all cancers, both in Australia, and very similar and broadly similar to the results with our colleagues at the CDC in the United States. We got organised with cervical screening in Australia around the late 80s, early 90s, and you can see that the introduction of the screening program around 1991 led to an acceleration of declines in both incidence and mortality. But since the early 2000s, these rates have plateaued, and this probably is the limit of the cytology-based cervical screening program. We're doing particularly well in Victoria, and I do like to show this when I do talks to show that Victoria is leading Australia. And here you'll see that as compared to Australia, which has a mortality of 2 per 100,000, Victoria actually has a mortality closer to 1 per 100,000. And that's probably due to a range of factors, but importantly, the way our services work together in Victoria and our follow-up rates for abnormalities. It's not all sunshine and happiness, though. Cervix cancer continues to be a disproportionate problem amongst Aboriginal and Torres Strait Islander women. They're twice as likely to contract this cancer and 3 times as likely to die of it. And our services are not accessible and not culturally safe for many Aboriginal women. Disappointingly, we don't identify Aboriginal and Torres Strait Islander women consistently within our cervical screening program, so it's very hard to see participation rates and abnormality rates. But this study conducted by our colleague Lisa Watt in Queensland has shown that consistently and at all ages, Aboriginal women are more likely to have a precancerous abnormality detected through screening. And this is most likely a result of the time since the last screen and under-screening, and a reflection of the appropriateness of our screening services for this community. So into this very successful cervical screening program came our national HPV vaccination program. We commenced as the first country in the world to offer publicly funded vaccination for our young girls in the first year of high school, and we did what remains the most extensive catch-up program to the age of 26. Uptake of catch-up vaccination exceeded expectations and has given us tremendous benefits, as you'll see. The school program added boys in 2014, and we have added routine catch-up for young women and men up to the age of 19, and that really is to cater for young people whose parents wouldn't agree for them to have vaccination. In 2018, we switched to a 2-dose course of the 9-valent vaccine, affording, as you'll see, further protection. The program has achieved high and sustained coverage, and particularly the 1-dose coverage is high, although we'd like it to be at 90%. The vaccination program is doing better than the screening program in identifying Aboriginal and Torres Strait Islander people. The green bars indicate where that information is not available. And over time, the National HPV Vaccination Program worked together with states and territories to improve that identification. This was the first publication showing comparing Indigenous versus non-Indigenous rates. And broadly, you see similar patterns, although not in all states and territories. Typically, what you see is there is a bigger gap at dose 3 than we see in dose 1. So if 1 dose proves to be effective, that equity problem won't be quite as bad. I'll turn to David, who'll talk about the impact of the program.
So obviously, when introducing a program of vaccination, you need to monitor its effectiveness. And it was very obvious, given the long time scale between a woman or a person becoming infected with HPV and developing cancer, the evidence for the effectiveness of the program would evolve over time in different areas. Our first evidence actually came from sexual health, where there was a very rapid fall in genital warts, and the protection against HPV types 6 and 11 was included in both Gardasil 4 and Gardasil 9, the vaccinations available in this country. But after that, we wanted to look at what was happening to HPV infections itself. And this study, performed by Professor Susan Garland, who works on the Parkville precinct and at the Women's Hospital, demonstrates the effectiveness of the vaccine in reducing vaccine types. The bar on the left, which is blue, shows unvaccinated. The brown bar shows vaccinated. And when you look at any type, there is not a significant difference. But on the right, when you look at the types that are protected by the original vaccine, 16, 18, 6, and 11, you can see a very rapid and significant fall in the number of infections. This was then further reflected by studies that were undertaken within the Victorian Cytology Register by Professor Julia Brotherton. And what we saw was that in women aged under 18 who were still eligible for screening tests, the amount of high-grade disease began to fall quite rapidly. And this was then followed by a fall in an older cohort subsequently, while the cohorts above that age didn't show initial reduction in high-grade cervical abnormalities. When we look at this over time, we get a much more substantial picture of drop. So each of the colored lines is a different cohort. You can see the purple line that women under 20, the abnormalities are falling steeply, followed by the light blue line at 20 to 24 years. And now we can even begin to see a fall in the green line after 2013 for the 25 to 29-year-old age cohorts. This would, of course, indicate a reduction in the overall total number of cervical precancerous abnormalities, which would then lead to a reduction eventually in the incidence of cervix cancer.
So this impact of the vaccine on high-grade abnormalities is actually an impact on the target of the screening program. We're looking for high-grade abnormalities to treat them while we're precancerous. And this was predicted to make screening a lot more difficult, essentially fewer needles, same haystack. And in about 2009, the Commonwealth commenced a program to renew the National Cervical Screening Program in light of the expected impact of the vaccine and also knowledge of new technology, including HPV tests. What we did was to look at what was then current practice. So the comparator was conventional cytology every 2 years for that age range. And we looked at a range of other strategies, including moving to liquid-based cytology compared to conventional cytology, adding HPV in various combinations, including, as is seen in some countries, particularly the US, co-testing, in which all participants get both HPV tests and liquid-based cytology. This was a really tricky and complex analysis, and that's because, of course, it was underpinned by literature review and the evidence. But for a range of things with the new technologies, there was not empirical evidence available, and modelling was required for that. And modelling, of course, was required for cost effectiveness. So please don't glaze over, because this is the most interesting cost effectiveness plane you'll ever see. And of course, typically on the top right quadrant with increasing outcomes, increasing life years saved and quality adjusted life years saved, there are increasing costs. We calculate a ratio and we compare it to what's called a willingness to pay ratio. So interventions that fall below that line are likely to be cost effective, and that's one of the major things that the government considers in determining whether to fund a new program. Of course, it's not the only thing. There are other considerations such as practicality, equity, and other things. So I've seen a large number of these cost effectiveness planes over all the committees I've sat on, and a lot of technologies that hadn't made it until the time we started looking at HPV screening. They've all been in the top right quadrant. But incredibly, with the orange dots being the various strategies associated with HPV testing, we were able to predict that we would get better outcomes for less money, so decreasing costs. I have never seen this in 20 years of being on committees looking at new technology. It's astounding. This is what it looks like for unvaccinated cohorts, and the pattern is the same, although the relativity is slightly different for vaccinated cohorts. So on the basis of that, we had our new program announced, and David's going to talk to you about that.
So the new program, based on the modelling, was accepted by the Medical Standing Advisory Committee in 2014 and was fully funded the following year by the Abbott government. The cervical screening test would take place, and it would be a primary HPV test in a liquid medium, and it would look for the 14 oncogenic types, and it would specifically look for types 16 and 18 that were associated with the largest number of cancers and are known to be the most transforming viruses. Any woman who had a positive HPV test would then get a reflex cytology test. If there was no HPV, the screening interval would be 5 years, starting at 25, with an exit test to be negative between the ages of 70 and 74. This screening test, which is a test applied to people who do not have any symptoms, would be applicable to all sexually active women, whether HPV vaccinated or not. There would also be the option for self-collected HPV test in a specific group of never screened or underscreened women over the age of 30. All of this would be underpinned by a new national cervical cancer screening register that would adopt and incorporate all the state registers into its data. And instead of reminding people that they had missed tests, women would receive invitations to test 3 months in advance of the usual date. it was anticipated from the modelling that these changes would prevent an additional 200 cervix cancers every year in Australia. Now, this led to an algorithm which is a little bit more complicated than in Pap tests, but essentially on the left is the green line. If you have no HPV, you come back in 5 years. On the far right is a blue line. If there is not enough DNA in the sample, you're asked to come back for another test in 6 weeks. On the red line, that is the set one in from the right, if you have HPV 16 and 18, cytology is performed regardless of the result. You're referred for a colposcopic examination. With HPV non-16 and 18, this is a group of a dozen viruses that can be associated with cancer, but are less oncogenic. It depends on the cytology. If you have a possible or a definite high-grade cytology, you ask to go to colposcopy. If it's low-grade or better or negative, then you can have a repeat test in 12 months. And if that was positive, regardless of the cytology, you would then be offered a colposcopy. The expectation was a significant number of women having a second test would be HPV negative and would then return to 5-yearly screening. Underpinning all of this was a new wiki guideline. So whereas cervix cancer screening used to undergo a 10-year catharsis and reproduction of entire guidelines in a printed booklet, the idea here was that we would publish the guidelines as a wiki, and then as new data emerged, it could be incorporated into the guidance. This was an extremely comprehensive review of aspects of HPV, of the causes of cervical cancer, of terminology, of how to manage specific conditions, and for the first time included chapters on colposcopy and treatment specifically. It's available through the Cancer Council Australia website. This change in program had a very significant impact on colposcopy services. And between the program itself was instituted on the 1st of December 2017. And as you can see from these figures from the Royal Women's Hospital that are based on financial years, from 2017 to 18, we saw a big increase in referrals, and that went up by more than 30% the following year. This was a consequence of the non-16, 18 HPV second test being more positive than we expected. And so less women in this intermediate risk group were returned to regular screening than the modelling suggested. As you can see, this had a fairly significant impact on our workload. Thanks to data manager Estefania and the head of the Oncology and Dysplasia Unit, Associate Professor Paula McNally, for these figures. So, colposcopy in the renewed cervical screening program, and this is data that has been collected by my colleague Jeff Tan from the 1st of December through to the 30th of June last year. Altogether, we had nearly 4,500 women referred with positive HPV screening tests, and over 40% of these were type 16 or 18 positive. And of those, 16% had reflex cytology, which was possible high grade or worse. Of these, nearly a quarter had confirmed high-grade abnormalities requiring treatment. Now, when the cytology was negative with the referral with 16 or 18, only 1 in 10 women had a positive histology requiring treatment, but that included 6 early cancers. When the histology showed, when the cytology was high-grade, nearly 90% of the women had confirmed high-grade cervical abnormalities. Looking at the more intermediate group of non-16, 18 viruses, if the cytology said it was going to be high grade, about 3 women in 5 actually had high-grade disease requiring treatment. But for those women referred with low-grade cytology or normal cytology, only 1 in 10 women had an abnormality requiring treatment, and there were no cancers. Women who have what is called a type 3 transformation zone, in which we cannot accurately see the part of the cervix we want to see because it is retreated into the canal, and that's usually associated with menopause, only 2.5% actually were found to have high-grade abnormalities. Colposcopy itself had a positive predictive value of about 70%, which compares very favorably with previously published studies, and was possibly higher than we had anticipated, given the change in the program. Our data was then sent to the Department of Health because we felt the sheer number of colposcopies being performed exceeded its usefulness. And data was then extracted from the National Cancer Screening Register that very similarly found that women with non-16/18 HPV and low-grade cytology had very low risk of high-grade disease and virtually no risk of even an early cancer. This led to a modification of the protocol so that women now who have only low-grade changes with non-16/18 HPV can actually be retested on 2 occasions and therefore have to have persistent virus for at least 2 years before being referred to colposcopy. The advantages of this are less requirements for referrals, less unnecessary treatments and harms arising from treatments, and it gives a nice example for how these guidelines have been more flexible than their printed forebears. So cervical cancer therapy has also undergone huge changes. This is a very high-level view of what's happened in my working lifetime. In the 1980s, cervix cancer was staged clinically. That is, it was based on examination and anesthetic. Most treatment for early stage cancer was with radical hysterectomy and full pelvic node dissection, which had its own issues in terms of complications, and radical pelvic radiotherapy with insertions of cesium implants for higher stage disease was effective, but not in all women. In the 1990s, we moved away from clinical staging towards staging through new radiological modalities and also the staging post-surgery. And this was backed up by the introduction of chemoradiation in advanced cases, which showed improved response rates and better survival for women who had some chemotherapy treatment in advance of radiation. In France and other countries, fertility-sparing surgery was pioneered by removing the cervix but preserving the body of the uterus and re-anastomosing it to the top of the vagina. This was possible in early stage disease and can be achieved through abdominal or vaginal operations. For more radical surgery, nerve-sparing techniques to reduce complications on sexual function and bladder function were introduced. Moving into the new century, we have intensity modulated radiotherapy being trialed to reduce side effects. And a published study in 2018 showed no inferiority in survival, but less complications. We were very keen to push forward with keyhole surgery for cervix cancer. And this was really performed from the early 2000s and through until 2018, when a randomized controlled trial actually showed slightly better survival with open surgery. And this has now been returned to as the normal treatment when surgical therapy is appropriate. Self-collection is going to improve the participation in cervical screening for never and underscreened women in Australia. We need to remember that 80% of cervix cancer in this country occurs in women who've never had a cervical screening test, or those who are underscreened or have lapsed from screening.
So in 2 decades of trying to recruit these women through a variety of letter and communication campaigns undertaken by agencies such as cancer councils and state governments, we've seen small bumps in participation by underscreened women. But really, I think self-collection gives us an opportunity to have a breakthrough impact on underscreening. Self-collection, provided we use a PCR-based HPV assay, is as accurate for the detection of CIN2+ as a clinician-collected sample. So under self-collection, the woman uses the swab on the left-hand side. It's a small swab to take a vaginal sample, typically within the practice, but offered privacy and supported to do that. The meta-analysis by Mark Arbin showed the receiver-operator curve on the right. So receiver-operator curves have sensitivity of a test on the y-axis and specificity on the x-axis. And the non-existent perfect test is up in the top left-hand corner. You can see there that the self-sample receiver operator curve almost virtually overlays the clinician sample operator curves, and the 95% confidence intervals are very, very similar. So we can be confident about the performance of this test for the detection of pre-cancer. And it is a lot more sensitive than the detection of pre-cancer with clinician-collected cytology. So the problem that we had when we came to introduce this into Australia is that none of the manufacturers had a self-collected device on their intended use documentation, and therefore it wasn't approved by the TGA. We at VCS Pathology wanted to offer this testing, but we needed to do an in-house validation study. We did this with David's team at the Dysplasia Clinic, and essentially consenting women collected a sample prior to their consultation, and then a sample was collected by the colposcopist. Those paired samples were transmitted to VCS, where we obviously tested them in our laboratory, achieving very high kappa scores, particularly for 16 and 18, and actually slightly higher detection of HPV in self-collection than in clinician-collected samples. And that's a finding that other investigators have also made. It's very important to us that these samples are stable over time. And these extended stability studies show you what happens to the CT value, which people know more about now in the COVID era. So over time, at 50 degrees and 100% humidity, you can see a very minimal drift upwards, but way below the detection line. So these tests work very well for 14 days. We have started to experience some delays in tests arriving to us from Central Australia. And for that reason, and not being able to test samples if they arrive after 14 days, we've actually extended these studies out to 28 days. And recently the regulators have approved our 28-day claim. So that's really important. The worst thing we could have happen is an underscreened or unscreened woman in Central Australia sending us a sample, and then for a technicality, we're not allowed to process it. Obviously, it's going to be interesting to see if self-collection is as accessible and acceptable to women as intuitively I thought it was going to be. We know cancers disproportionately affect Aboriginal and Torres Strait Islander women, as we've already shown you. Also affects some culturally and linguistically diverse communities, particularly people coming more recently into Australia, coming from countries where there is not good screening, and also economically deprived women. So we did these acceptability studies in the agencies you see below that were serving these communities, and across all three groups, amongst women who had said no to a pap smear. So this was prior to the new program. 85% of us gave us a sample. So the practitioner, the nurse or doctor offered the sample, and that was undertaken during the course of the consultation by the woman herself. We powered the study to ensure that we had enough HPV positive women to determine whether we could get them to follow up, because there's no point in self-collection primary screening if you can't do the analysis, the workup and treatment of HPV positive women. And you can see with appropriate support, more than 9 out of 10 women who are HPV positive were appropriately followed up. And I'll leave you to read those quotes that came in through the qualitative work. This is a breakthrough. We've rarely got to 85% participation, never got to 85% participation or anywhere near it through any of our other strategies over the last 20 years. So this is very exciting. What do we think is going to happen with our new programs? So this is modelling from Karen Canfell's group in Cancer Council New South Wales, a collaborator with us on the C4, Centre for Research Excellence. And what you see here is, as we have transitioned to a more sensitive test, the HPV test, we see a transient bump in the incidence of cervical cancer, as we do in the high-grade abnormalities. But that transient bump is due to earlier detection and effectively downstaging of some women with cancer, and therefore the modelling does not predict any increase in the mortality arising from cervical cancer. We're expected to reach the elimination strategy by 2035. I'm going to end this section with a quote from my colleague, Dr. Lisa Watt. Australia is going to reach elimination probably and arguably first in the world, but it needs to be for all Australian women, and we've got to keep our eye on the ball with equity. So David.
So while Australia and some other high-income countries are doing well in preventing and treating cervix cancer, it is good to remember that nearly 500,000 women per year are diagnosed with this disease, and more than 250,000 women a year die. In May 2018, the World Health Organization Director General, Dr. Ghebreyesus, called for global elimination of cervix cancer as a public health problem. And this had become a real priority consequent to the success of the WHO's policies in reducing maternal mortality. In a sense, it kind of revealed the problem worldwide of cervix cancer in younger women. This map is really an intensity heat map of where cervix cancer occurs in terms of the incidence. It will be no surprise to you that the majority of countries are poorer, and particularly from sub-Saharan Africa, Latin America, Southeast Asia, Eastern Europe. And we would note there is particularly high incidence in Papua New Guinea and other smaller island nations that cannot obviously appear on a map of this size. Without intervention, there will be 44 million cases of cervix cancer between now and 2069. These will mostly occur in low and medium income countries. A rapid scale up of vaccination with 80 to 100% coverage could avert 6 to 7 million cases of cervical cancer. HPV screening with 2 lifetime tests in low income countries with 70% coverage could avert somewhere between 12 and 13 million cases by 2069. Widespread combination of vaccination and screening could reduce the incidence to, by the end of the century to less than 1 per 100,000 in very high income countries, 1.3 in high income countries, 4.4 in medium income countries, and 14 per 100,000 in low countries. And that incidence is currently less than the incidence of cervix cancer in Japan. This study conducted by Kate Sim and from Karen Canfel's group shows what will happen if we don't do anything. And that is essentially the line at the top, moving towards more than 1.5 million cases of cervix cancer globally by the end of the century. The bright green line at the bottom is really an absolute perfect scenario in which we obtain very high levels of vaccination and screening almost immediately, and is actually thought to be impractical. Where we would like to aim ourselves is on the light green line, with a combination of practically achievable vaccination and screening that would bring the incidence of cervix cancer to the elimination threshold set out by the WHO by the end of the century. The global strategy comprises 3 main points. It is that 90% of girls should be fully vaccinated with the HPV vaccine by the age of 15. 70% of women are screened with a high precision test by the age of 35 and 45, and hopefully that will be an HPV test at the point of care. And 90% of women identified with cervical disease will receive appropriate treatment and care. And this strategy was adopted by the World Health Organization at its assembly in August 2020, in which Australia was a co-sponsor.
Thank you, David. As you can see here, vaccination has not been rolled out in the countries that need it most. So the blue countries are high-income countries with pretty good screening. Together with Gavi and PATH, a pretty good job has been done in South America and parts of Africa, but there are still very big gaps. And this has been hampered by manufacturer capacity, which is being addressed. We do expect vaccines that have been developed in China and India to make their way through regulatory approval and increase the manufacturing capacity in the coming year or so. Delivering vaccines to billions of young girls around the world is going to be challenging. We started with a 3-dose schedule. Work led from Canada in particular and others showed that a 2-dose schedule achieved the results we wanted, and that is now the schedule recommended by WHO and countries around the world. However, as you'll see in this slide, there's some tempting data to suggest that perhaps a single dose of the HPV vaccine would do the job. And this would certainly mean we could reach more girls within the context of the global shortage and also logistically make this vaccination delivery achievable in very challenging circumstances around the world. So in this background, we conducted a study where we linked the Victorian Pap Test Register to the National HPV Vaccination Register and essentially compared the probability of developing a high-grade abnormality that was proven by biopsy. In the pink line at the top are unvaccinated girls, and the other 3 lines, which you can see are indistinguishable, are 1, 2, and 3 doses. So this adds to our hope that the randomized control trial evidence that will be coming in this year will confirm that a single dose will do the job. And that while this evidence that we've generated is ecological, we do need to see the RCT evidence before the WHO and countries around the world will change their schedules. I just want to take a couple of minutes to talk to you about some work we've been doing in Malaysia in Clinic Kesihatan. These are government-funded public primary health clinics that see the least resourced women in the Malaysian community. And we undertook this project in conjunction with Professor Wu Yinling, my friend, a gynae-oncologist who had trained in gynae-oncology in the UK and was shocked when she came home to Malaysia to establish her practice to see that although there had been a screening program in Malaysia since 1969, the rates of cancer and the stage at which cancers were presenting were very high. And she was seeing a lot of women who she could not cure of their cancers and who died not worrying about themselves, but about their children. And these are the sort of typical things that you see in these clinics. Trying to get pap smears done in these crowded environments is practically impossible. And we know that uptake is around 20% at best across the country. There's no formal screening registers such as what we are used to. So we had a number of visits from Kuala Lumpur to Melbourne and from Melbourne to Kuala Lumpur, and that's Yinling on the right. And we talked about how we could do something that would work. And this was very much a partnership. We had some technical expertise, but they knew what would work on the ground in Malaysia. And what we came up with was the ROSE solution, as we call it now. We changed from pap smears to self-collected HPV tests, and we supported them with a mobile version of our screening register in which nurses registered patients using their mobile phones to log in securely, and we communicated the results to women through their mobile phones. Now, this was 2 years before this became quite common with the pandemic. Importantly, the Rose Foundation now uses that telephone number to communicate with women, and as you can see, more than 90% of screen-positive women are engaged in care. There's a lot of interest in funding HPV tests, but not a lot of people who understand that that won't work unless we follow these women up. Overwhelmingly, women just love the approach of self-collection and getting the result quickly. I'm going to turn over to David for the...
As you can witness, a huge amount of work towards cervical cancer elimination has been undertaken by organisations on this precinct or associated with this precinct. And I wanted to pay my respects and to honour some of my colleagues who've done a huge amount of work in both preventing cervix cancer and alleviating suffering from women who have invasive disease. Dr. Jeffrey Tan is one of the most humble, quiet, hardworking, and achieving gynecologist as a colposcopy expert that I've ever met. He was one of the founding fathers of the Asian Society for the Study of Genital Neoplasia. He was the creator of the database, which we have used up until this year at the Royal Women's Hospital, and gives us so much valuable data. And he is an educator who has worked tirelessly across the region, and founding connections to Mongolia, but also teaching in Fiji and other island nations. And he remains an active clinician and researcher within our unit, and someone I'm very proud to call a colleague. Professor Susan Garland has a long history of studying HPV, both its natural history and the impact of vaccination. She trained in Melbourne, but has also had a fellowship in Harvard. She has been the Director of Clinical Microbiology at the Women's and Children's for more than 25 years, and is now Professor in the Department of O&G at Melbourne and the Clinical Director of Microbiology and Infectious Diseases at the Women's Hospital. She's an advisor to the WHO on reproductive health, has published innumerable studies on HPV and its impact and and the impact of vaccination, and was the inaugural president of the Asian Society. Professor Michael Quinn was for more than 20 years the Director of Gynecological Oncology at the Royal Women's Hospital. He originates from Scotland, trained in gynecological oncology in Melbourne, and has published more than 350 articles. He also has an interest across the world in research and education, having been chair of the Intergroup and a recent president of the International Gynecological Cancer Society. As a sideline, he's raised millions of dollars through marathons and cycling, but he's also, very importantly, the founder of the IGCS's Fellowship to Train Gynecological Oncologists. And we are hopeful to work in partnership with IGCS to gain fellowships for people working in island nations and Asian nations in order to give proper treatment for women who have invasive cervix cancer. Professor Kailash Narayan was trained in India in medicine and biophysics. He did a PhD at Australian National University and trained in radiation oncology in Auckland before returning to Peter MacCallum Cancer Centre, where he was head of radiation oncology for gynecology from 1996 to 2019. He's professor in the Department of O&G at Melbourne. He maintained a unique database of all cervix cancers treated during his tenure and achieved an extraordinary record of survival, increasing year on year. He pioneered ultrasound image-based conformal brachytherapy, which allows doses to be tailored more accurately with fewer side effects, in conjunction with his colleagues David Burnshaw and Pearlie Kaur.
So I think we'll wrap up by saying that not only is Australia, but Victoria really is a world leader in cervical cancer control, particularly screening, prevention and treatment. Remind you that in August last year, the WHO adopted the strategy of global elimination of cervical cancer as a public health problem. We're very optimistic that self-collection is going to be a tool to drive equity in disadvantaged and underscreened groups. It will be acceptable and scalable in low and middle income countries. We're only the second country in the world to have moved our successful PAP program to one based on primary HPV, and this, together with our very successful HPV vaccination program, should see us as one of the first countries to reach elimination. I think what we've tried to show you is it's critical that we use our technical expertise and our abilities to work in partnership with colleagues throughout the Indo-Pacific region, so that it's not just Australian women that benefit from this, but women in countries of the region who shouldn't be dying without treatment of renal failure from an entirely preventable cancer. So I think we'll leave it at that, David.
Thank you so much, both of you, Marion and David, for your fascinating insights. Certainly some very exciting development indeed in efforts to eliminate cervical cancer in Australia by 2030. We'd love to come to your questions now. We've got a few waiting for us, actually. If you've got one in mind, you do have time to quickly tap one out now. If you like, you can do that via the Zoom Q&A function. The first question we have is from Emma Royal. When vaccinating older women up to the age of 40 or so, does the 2-dose regime stand or 3? That question's from Emma.
Well, as far as the evidence is based and the license is based, the quadrivalent and the nanovalent vaccines are licensed for women to the age of 45. And the recommendation at the moment is still that there should be 3 doses. But I think it is fair to say there should be some investigation of the possibility of 2 doses separated by possibly 6 months in order to release other doses of vaccine for places where they may be usefully given to younger women with a single dose effectiveness.
Second question we have from Avluir. Great success in Australia overall. What are we doing to support similar programs overseas? Is it really possible to replicate the success we've had here in poorer countries? What would you say, Marion?
Look, I think that's a great question. And I think what Yin Ling taught me is that in Malaysia in the 1960s, they tried to replicate the screening program from the NHS in the United Kingdom, and it just didn't work. So the question's very insightful. I mean, I think with the self-collection technology and also new treatment technology for pre-neoplastic disease, so thermocoagulation, I think we really can make a difference in these countries, but we have to be realistic. We have to work in partnership with the experts in those countries about what will work there, and not try and just impose a kind of Australian way of doing things on those countries.
I guess there's a certain element of diplomacy that you've got to exercise as well when it comes to that.
Yeah, I think that's right, but also an understanding that we're not going to get a speculum into the pelvis of every woman across the planet twice. That's 7 billion eligible women. So being really pragmatic about what works. And I'm just very optimistic that we'll have single-dose vaccination and self-collection really accelerating cancer control in these countries.
You don't often hear positive stories like this in the cancer space. There's a question from an anonymous attendee here. Thank you for sending it in. Thank you for sharing the exciting data about self-collection. Is this currently available? How do you find out? Do you get a kit in the mail like with bowel cancer screening?
So in Australia at the moment, for regulatory reasons, and because when we set the policy, we didn't have the updated evidence about the performance of the newer technology tests, the self-collection policy limits self-collection to women who are overdue for screening and at least 30. And I suppose what we could do is send out some information to people about how to access that or how to make it available. There are 2 labs in Australia, one in Sydney and our lab here in Melbourne that are validated for processing self-collected samples.
Marion, how long would you expect it to be before this becomes part of cervical screening in Australia?
So there's currently a group that is considering that in the Department of Health, in the Federal Department or the Commonwealth Department of Health. And it's a policy change that will need to go through the Medical Services Advisory Committee process. So anyone in the audience who's looked at new therapeutics will understand that that process takes time. I'm anticipating it's 18 months to 2 years away. And I think what will happen is it will be self-collection or a pelvic exam at a woman's choice, actually. So empowering women to choose how they want that test collected.
When it comes to the study that you did around this, with the breakthrough high participation rate, that was fascinating. Were you surprised at the large numbers of people who agreed to participate?
No, I wasn't, actually.
Why not?
Well, look, I'm in my late 50s. I've been finding the pelvic exam increasingly uncomfortable as I age, and actually I was overdue by 2 years when the program started, and that's how I screened. And we've known about the barriers to screening for ages, and there are cultural barriers, there are barriers of trauma, and all sorts of things that make it impossible for some women and difficult for many of us to have a pelvic exam. So I did think it was going to be highly acceptable, and I was pleased that it was. Really, really very excited.
Yeah, it's really exciting and impressive. We've got another question here. Are some cervical cancers not caused by HPV? If so, does this risk missing these, David?
In fact, we do know there are some rarer types of cervix cancer that are not related to HPV infection. The problem is that even under the PAP program, these were not detected. So I think we have to define very clearly the difference between screening and investigations. And screening is what you do to people who have absolutely no symptoms, and you're trying to detect abnormalities that they are completely unaware of. If a woman has symptoms, abnormal bleeding, particularly bleeding after intercourse, she should see her general practitioner and request appropriate examination. In those circumstances, a test is taken from the cervix that looks for HPV and does the cytology, regardless of whether the HPV is positive or not. And that's one of the ways in which we hope we'll be able to pick up some of the non-HPV related cancers. In relation to the new test and the increased interval, what I say to a lot of women, based on studies that were performed in the Netherlands and elsewhere, a 5-yearly negative HPV test is twice as safe as a 2-yearly PAP test. It's that much an improvement on the old technology. So every woman should have confidence, not just in the test, but in the parameters of the new screening program.
Thank you for that. Another question, what are current recommendations for young men regarding vaccination against HPV?
So boys have been included in the national HPV vaccination program since 2013.
What ages do they receive that?
Boys and girls receive vaccination in their first year of high school, essentially.
But any for young men?
So up to the age of 19 is funded. And as I said, up to the age of 19, particularly to cater for young people whose parents haven't agreed to them being vaccinated, who are then able to make their own decisions for those 2 years.
And I think we've got one last question here. Don't forget, if you do have one, you can find a point to ask your question on the Q&A button in your Zoom screen. The last question we have for now, you mentioned that screening is now every 5 years. I thought it was every 2 years. Can you please explain why that is, David?
It's because of the change in technology. Right. So the PAP test involved literally scraping cells off the cervix, smearing it on a slide, and then putting a special stain on the slide. The average slide contained 350,000 different objects, which the screeners looked at to try and detect abnormal cells. What we do now is we take a sample from the cervix, goes into liquid, and the robot processes it with a much more sensitive test. And detecting HPV is also detecting the problem earlier in its natural history. And that is why we can safely move to a 5-year interval for an HPV test when a 2-year interval was needed for the PAP test. Also, the cytology that comes from a positive HPV test is created by a robot. It has less blood or other problems associated with it. It's a cleaner sample for cytologists to look at. And in fact, AI can examine some of those slides and tell the cytologist which objects they should look at. So all of this is an enormous technological advance, providing a much safer and a much more sensitive test.
How much do you think the rebranding from pap smear to HPV screening has helped as well? There's been a bit of a name change there.
Yeah, look, I think people know the PAP test very well. I think less people know the origin of PAP test. Dr. Papanikolaou, who was the Greek doctor in New York who devised the stain to stain the cells. And as typically in rather Australian, it's become abbreviated to PAP test. The process that women currently go through and experience is no different. So the physical examination they have is no different from the PAP test, but they are getting a much, much better, more sensitive test.
Thank you for that explanation. And that seems to be all of the questions that we've had thus far this afternoon. So that brings us to the end of today's Monday Lunch live stream webinar. A huge thank you to both Marion and David for your presentation today. It was so interesting. And to you, our audience, for tuning in today, whether it's tuning in live or watching it a little later on. Next week is the Labor Day public holiday, so there'll not be a Monday Lunch live stream event. But on the 15th of March, you'll be able to tune in for a special presentation, how playing with Lego can help understand the spread of breast cancer, with Dr. Jean Berthollet. Thank you very much for joining us today.